Again, welcome everyone to the Fragility Fracture Registry web, I guess it's a webinar, education session. So tonight or this afternoon, I'm going to go through the registry and show off what we've got, what we've built so far, what's being used, and then also what's coming, and then Curtin is going to share where ethics is and what progress has been made there. So let me start by sharing my screen. So this, and it hasn't gone green for me yet, so I'm not sure. Tell me if you can see this. Curtin, give me a thumbs up.
Not as yet.
It's just gone green around it now.
Okay, good.
So this is the fragilityfracture.com.au website. This is sort of like the home, if you like, for the Australian Fragility Fracture Foundation. So the foundation was created to hold the IP, receive grants, and promote the cause of reducing fragility fractures in Australia. When you've come into this site, this isn't the registry. This is just the website that talks about that. And here we are at our education session. But if I flick to the registry itself, so this is, you'll see at the top there, demo at .fragilityfracture.com.au. So this is the demo site. When you first come in to the demo site and log in, so each user has their own login and security level. I've logged in as the user site lead, so that's first name and last name, just so that you, when you log in, Curtin, it would be Curtin Gander, Marcus Siebel, David Lewis, etc. And if you're a site lead, you get more opportunity to do stuff than you do if you're just a site user. You can set up more users if you are the site lead. What we're seeing here is the dashboard. So the dashboard shows off all the things that are going on for you locally and then nationally. So if I say, show me, just show me all records and hit refresh, we'll see that there are 49 records nationally, 46 at the local hospital. Welcome to those that just joined us. A few more popped in. So the registry itself, this dashboard was pretty much put together reasonably quickly. And please forgive me, while it says .com.au, obviously I'm showing New Zealand ethnicities here. That's not going to be what you would see in Australia, but the standards would all be the same.
So yeah, Stuart, thanks. And I'll just chip in to say that so all these KPIs, we worked in close collaboration with New Zealand to obtain these KPIs, and it was all based on the IOF Capture the Fracture Standards document that outlined the 10 main KPIs for fragility fracture services. Basically these would be auto-populated once the data is entered. Is that correct, Stuart?
Yeah. So this is reporting real time. So this is showing you if you added a new record now, all these numbers would change. And yeah, this is sort of so that we can compare apples with apples around the world. You have the ability to show, so if I show last year, at the moment, because we're in demo, it's showing calendar year, but for the registry itself, the live one, actually runs financial year, Australian financial year. So from the 1st of July till the 30th of June each year. And so if you said last year in the live site, it would actually go to the last financial year which would be ending 30th of June 2022. I won't spend too long on this because I'll show you another one in a minute. In Australia, where we have Concord Hospital entering data, and I believe Western Health will be joining us soon, and there are more signing on. In New Zealand, they have a blanket system where everybody was required to enter data, and I think all but one site is currently entering data, and they're seeing about 50 records a day go in across the system nationally. But this isn't just to capture data. This is been designed to be a system that actually helps you track patients and see what's going on. So I've clicked on patients there. So these are all my patients. You can view them by whether a DEX has been ordered, whether they're up to intervention, follow up at 16 weeks, follow up at 52 weeks. These are all the ones that are fully completed. And of course, patients can opt out. With the opt out, we keep them in the system. We mark them as opted out. Once a record has been opted out, it won't appear in any of our reporting. So because they have opted out, the reason we leave them there is if somebody else comes along and doesn't see the record, they may put them back in again. So this is a way of capturing and making sure that anyone who decides to opt out is actually opted out. Some other things you can see here. If I hover over, say, David Auckland there, or Betty opted out, you can see the on the right hand side here, it gives me a summary, some summary information. So at the moment, we've decided to pull out the email, the index fracture date, the index fracture itself, and the patient notes. This is we have the ability to modify this as we see things that are more interesting. But I'll go into a particular record now to show you what the data set looks like. So the idea is this has been built to be easy to enter. So the only mandatory field at the moment is the index fracture date. That's the only one that you must put in before you can save it. You can actually have no name, but it makes it really hard to work out what patient it is, so I wouldn't recommend you do that. Medicare number is checked. Date of birth will give you their age, sex and Indigenous status. All of these drop downs pull live from the system. There's our little opted out button. Here's your patient notes. And so the way the system has been built is to capture the initial, so the index fracture, whether it's a fragility or atypical, and then whether they've been admitted to hospital. Because I'm on demo, some of these drop downs will do odd things. So forgive me if the live system does actually show all this stuff.
And the other point is, Stuart, you can easily enter this very quickly and efficiently, potentially even with the patient with you at the time.
Yeah. So the system, this has been written to be tablet friendly. So if you can log in using an iPad or Android tablet and actually fill it in right there on the spot if that's something that you want to do. That's why, again, the index fracture date is the only field that we make mandatory, because you might want to put in the Medicare number and then go and fill in the rest later. And the Medicare analysis, you find what the patient is. We have a set of tabs along here, but sometimes it might be that the patient has, it's appropriate for further assessment, no. For whatever reason that is, the reasons over here will then drop down. And if it's no, well, you're finished. That's it. Nothing more to add. And when we look at the patient list, and I'll show you that again later, it would just show you that this particular patient is completed now, nothing more to be done. However, if there is more further assessment, if that's a yes, then all these become available again. And we move on to the investigation bone health assessment. So there's, I don't know, are there any of these fields particularly that you want to sort of address, Curtin?
Yeah, so just to the background to this is that you can see these fields are very similar to, for example, FRAX, covering the risk factors for osteoporosis, and we've used that as basically trying to determine if someone's assessed their clinical the osteoporosis risk factors, and within this schema, there's also, with this, there's a data dictionary, which is a much more detailed document. But if you look at the more up-to-date database, there's info tabs where you can click on current smoke and how it's defined, or alcohol use and how it's defined. So that process, we're hoping, is smooth again, so that you don't have to refer back to the data dictionary continually. And I guess on the one hand, we were trying to simplify the data set as much as we can so that it was user-friendly and didn't involve too much data entry, and whilst keeping it very relevant clinically for the FLS.
Cool. So we have the ability to add some of these extra instructions here. You can see there's the definition for FRAX, and if sex is male, then early menopause disappears, that sort of thing. So the idea is to keep it as simple as possible, allow you to fly through the fields, put in what you know, leave out what you don't know, and save and close. After bone health assessment, we've got falls risk assessment. At the moment, these dates from here will copy into there again, because for the majority of cases that certainly, and I know this happens in New Zealand, it's the same date. It's always the same date. It happens at the same time. So that's a possibility. If that's not what happens here in Australia, we can change that. And then we just sort of ask the basic questions: fear of falling, pre-fracture strength, falls related referral for assessment, and what's likely to happen here. Anything more, Curtin, you want to add on that?
No, I think again, there's free text here about what happened, and that sort of we try and cover that in detail, mainly because then I guess we can show you a bit later how it can all be, formatted into a letter, if that's possible, Stuart. But the idea behind this was to detail the falls, relatively as comprehensively as we can, as we could. Yeah. Cool.
All right, so we've recorded what happened and any extra fields here. If we move on to DEXA, whether it's been ordered or not, the order date, the date that it actually happens, and then the results. Again, all of these fields from here all the way through can be put into a letter, whether it's a letter to the patient or a letter to the GP. And we can define what that is. I'll keep moving through the data set itself. So in terms of intervention, what intervention occurred, again, so here there's a list of medications, although one of the options in here, and I'll show you this if I get a chance in the live site, is not clinically indicated. If it's not clinically indicated or the patient refused, these two follow-up tabs will disappear, and that will be the end of it. Like, that's where the patient journey ends. they've decided either they don't want to be involved or it was not clinically indicated. So you would just fill
and
out
the list is quite comprehensive. I mean, if you look at the drop down for the medications, for example, it would cover everything that is available in Australia at the moment.
Very cool. So that sort of completes that part of the journey, and then we have the options for a 16-week follow-up. So yes, no, uncontactable, declined, or patient died. If patient died, then you won't, or decline, you usually won't see the 52-week follow-up. If anything else is means that you probably will, so we just leave that there. And then on the follow-up, we ask a few different questions. But that's sort of the patient journey through here. There's quite a few things to tick and flick, but the idea has been that to make them really quick and fast to enter, so that it isn't a huge data entry burden.
Yeah, and so yeah, as you mentioned, Stuart, the fractures, falls and fractures are captured at the 52-week mark, and then from talking I'm not sure how, in terms of the timing or how long it would take for one person to enter the data. It looked, you know, roughly when I was talking to Mawson, the registrar that was working with us last year, it said, you know, maximum would be 10 minutes or 5 to 10 minutes to enter all this data in.
Cool. Now, as we said, you know, we want the ability to be able to do interesting things with this. So you can, from this data, you can use this to populate letters and then save them as PDFs, or cut the text out and send it as an email, or send it. At the moment, we haven't built in be able to email directly from here. But I'm working with the folks in New Zealand with a new patient letter and a new GP letter or doctor letter, and it will give all the information. So it will show. I'd show the whole form, but it's a bit messy at the moment. But say you've got the option to generate a number of different patient reports. And if I just do that one, fires it up in a new window. That's the basic of it. Puts it in here. We can then modify that. Save the report and save and download and do things with it that we need to. If I go close that off and go back to here, you'll see I've generated one already under view letters, and that sticks with that particular patient record. So if you had generated a bunch of letters, you can see when it was generated, and then click on that, and that will show you what was written and what was sent. All right. So
are they using this in New Zealand?
No, not yet. So they want in New Zealand, they want a global letter. So not site specific. So the system has been built to be allowed for site specific letters. But in New Zealand, they want to spend some time and actually have, you know, letters for the patient one, for example. I don't know if you can see my screen, but it has graphs and pictures of food. And so what we'll do is we'll generate that based on the data that's been entered for that particular patient and save it. And rather than do it as PDF, we'll do it as a Word document, so you should make it easier to share and edit and do things with later. But yes, no, currently it hasn't been used yet in New Zealand.
Yeah, thanks, Stuart. Maybe should I run through this, just a brief outline of the ethics side of things?
I'm just going to open the floor up to questions because I've just covered a whole lot of stuff. and then I'll quickly whip through the follow-up, show you that one, and then I'll flick to you for ethics, if that's all right.
Yep.
Are there any questions from the floor?
Yeah, I just my name is David. I'm one of the trainees at Concord. Firstly, it probably just takes 5 minutes to enter the patient data. It's really very quick.
Cool.
I just had a question about the information packages, because I just wasn't familiar with those, and it was sort of, has the patient been delivered the information package? And just wondered if you could tell me about that.
Yeah, so this was generated, this one hasn't really been tailored to Australia. So the information packages in New Zealand, they have a thing called the Know Your Bones one. They have a standard package which just has lots of information about osteoporosis and what's, and so we can tailor that to whatever we are likely to hand out here in Australia, but it just hasn't been done yet, David. Sorry about that.
Oh,
Yeah,
no, that's fine. That makes sense.
And David, the other point to make there is, if there is, where I can show you, share the data dictionary with you, which details what it means by information package. But from just in summary, it's basically whether the patient was given information regarding, calcium intake, sunlight exposure, exercise, and as a sort of like a pamphlet. But there's also the Garvan has a website called Know Your Bones, and in New Zealand they've been suggesting that everyone gets referred to that website, so the patient or their relative can have a look at that, and that helps people, educate people about osteoporosis risk factors a bit more.
All right, I'll slip you the fiver later, David, because that takes me neatly to the documents. So everybody gets access to this, and under here we have things like falls guidance, but that's the data dictionary, and that describes every term with every data point and what we mean by each one. The last thing I wanted to show off was the follow-up calendar. So there are two different, you see reds and blues. Blues are the 16-week follow-ups, and the reds are the 52-week follow-ups. And this is being really heavily used in New Zealand. So they'll actually bring up their calendar and then look at, okay, who should I have done last week? And they get really excited when they can go back 3 months and there's nobody left. So the moment you've done that for particular follow-up, it doesn't show up in the calendar. And they're using that as their quality control to make sure they've actually done all of them. And the same as before, if you hover over each one without clicking, if you click into it, it just brings up the record. But if you hover over it, you can see, some of the information. Dementia, speech to daughter. I think that's it for me from the registry itself. These are the main points that I wanted to cover and just sort of show off what these look like. We are looking towards doing state-based reports, comparing hospital to hospital and actually having charting and stuff as well. Again, that will, same as the hip fracture registry, that will all be available real time. Was there anything that you guys wanted me to drill into a little bit more or ask about before I hand over to Curtin to talk ethics? Awesome.
I'm sorry, just to reinforce what David just said. So Mawson and David have entered data. We started last year, and now David is continuing, and it really only takes 5 minutes to enter the data. And I just want to point out that once you have your patients in the system. It is really a patient management system, which is extremely useful to, for follow-up. And as you just pointed out, Stuart, nobody falls through the cracks, etc. So it really is much more than a registry. It is a really important or very useful tool for your clinical work. And as I said, so as David pointed out, it doesn't take long to enter the data.
All right. I'll stop my share there. In fact, is anybody interested in what's going on in New Zealand, or should I just skip that?
That'd be interesting. They're so far ahead of us.
All right. So I've logged in on a different screen, and that should pop up any second.
Yeah.
Right. So this is New Zealand for this year. We're at the 23rd of February, and they've already got nearly 6,500 records in. At the moment, I think they're averaging at about 50 a day. And since we started, that number, give it a second to catch up, is about 8,007 records. So they're absolutely powering along. And what they're saying is we're in discussion at the moment to look at whether we split up the 12-week patients and these 16-week patients and the 52-week patients into different cohorts for reporting, just because there are so many different patient groups and timelines. But yeah, they're certainly cracking on. As I said, I think 53 a day at the moment is they're averaging in New Zealand, new records. The other part that I'll mention is that we are doing the other project that we're doing is joining the hip fracture registry and the fragility fracture registry. So if they exist in one, the data can be copied to the other fairly quickly, to save on duplicating the data. All right, we've had a few new people join. What I'll do is I'll grab your email addresses and make sure you get a copy of where we started, because you've missed the demonstration of the registry itself and or as Marcus would say, the patient management system. But I'll hand over to Curtin to talk about ethics and what would be the next stage if you wanted to get involved.
Thank you. Thanks for that, Stuart. It's good to see. It's nice to see how New Zealand are entering so many, and I guess that's at least we've got the potential in the future as well, which is nice.
It does show the system can handle the data.
Yeah. Yeah. So I guess just to this project, I think I've talked to most people about the the Fragility Fracture Registry, and it's been a work in progress for a couple of years now, and fortunately we managed to get approval from our local ethics for Concord Hospital and Western Health at the end of last year, and that was a nice milestone to get through. And now the idea, we also one of the hurdles we faced was also getting a host server, which we eventually did get via Sydney Uni. So there's a cloud data center where all the data is hosted, and so it's a top-notch, secure sort of a cloud-based server. So that's been we've been quite happy with that. I thought I'd share some of the documents just so you're kind of familiar. You can see what's been sort of involved, and when the process, which, for example, now we've included Western Health in the original ethics application via Regis, which is the national, which is a national online portal for ethics applications that we use in New South Wales. But it's applicable nationally, but simply ask for a site-specific application, which involves amending the opt-out consent forms, pretty much, and getting a data transfer agreement, and then they'd be ready to go. As for other sites, we didn't specifically include in the ethics application or name those sites, so I can easily share the whole application with the individual at your site who's responsible for ethics applications, and that I can share that together with the approval letter. So I'll just show you maybe, this is our final approval letter, just so you're kind of can view that. So basically we had that basically in October last year, and I'll send this through, but basically it's the approval for the registry, and we've submitted a number of documents, but probably the main ones were the protocol and the opt-out information sheets, and then obviously the actual data set with the data dictionary as well. The other thing I wanted to share with you was just the patient form, which kind of summarizes the. I don't know if you can see the form there. Yeah, so that's the actual summary form, which sort of outlines in a little bit more detail, but I guess you can see again the patient. It's very clearly set out, so that made it useful for demonstration purposes and for people in ethics viewing our application. So that's again similar to what Stuart has shown you already. All this stuff, which are all drop down lists, and then the investigation side of things, the DEXA again, and the follow-up, which are quite brief. So the 52-week follow-up will be quite quick to enter, I would say. Then we have I'll just show you the opt-out consent as well. This is just and we can basically, this would be this is the template, and each site will just add the study site and the study coordinator basically, and we're hoping this will be appropriate for everyone to use. So it is quite a long document, which we sort of couldn't get away with, but as you can see, it's more giving patients who are captured by the FLS this form to inform them of their what will happen to their data, and they've got the option of opting out, you can see via email or telling the staff at the time. And finally, I'd very briefly show you oops, no, that's not the one. Data dictionary, which is here. And just to illustrate, it is quite a detailed document, and it's how many 70 pages long. But yeah, it's, for example, you could sort of I'll just show you one example. There's the Aboriginal and Torres Strait Islander one, or you can say the index fracture, and it again outlines how do we define the index fracture and the sites that we're using and what the sources of the list was, and so on. So I guess this is a really good reference document. But I think, practical purposes, this is more if you have questions. I guess you can always email us questions, Stuart or I, if there was any query in relation to any of the data points. But it's mostly when you log on to the database itself, I would say it's self-explanatory, and we've got those information buttons there, which makes it much more very smooth for the individual entering the data. Yeah, so maybe I might ask if Marcus would like to make any further comments, and also if we're happy to take any questions that you may have.
No, as I said before, thanks, Kitten. As I said before, I think it's a very useful tool. We've been using it now for over 2 months, I believe. And it's the data entry is quick. And as I said, it's a management tool. It's very useful. The point, of course, is we need more sites to come on board and enter data. Without that, we're not going to get funding. We are obviously looking for funding from the government, but we need to show, obviously, that the registry is being used. The linkage with the hip fracture registry is certainly a great idea. Also, the development of, that you can produce letters out of the registry, out of the data in the registry. That's a fantastic idea. But the major thing really now is to get sites on board so that we can show the registry is being used, and we can, apply for funding from the government. Basically the same process as many years ago for the hip fracture registry.
Chris, you've got a hand raised. Are you able to unmute?
Yep. Hi guys, how are you?
Yeah, good.
Yeah. Thanks for that. I'll take the hand down. Look, I'm just curious. Have you mapped this to a common data model? Is this mapped to OMOP?
What do you mean? The common data model, as in we've based the data points on mainly the FLS standards.
Yeah, okay. No, I'm looking for interoperability between data sets. So if you want to actually integrate between registries, if they're mapped to a common data model, then they become integrated very quickly. So there's a lot of, if you want to go for money with, particularly with infrastructure grants these days, there is a great push and a community of practice around using an international common data model, which is usually OMOP, particularly so you can get integration with European data sets. If you looked at websites like Hassanda, and just so that the registry doesn't become isolated in its utility and usability, because there is certainly a push among data registries to be secondary use of data and interoperability between these data sets.
So the hip fracture registry used pre-existing Australian standard data points, which is why they all look the same. And we have adopted those. So we have full interoperability between the Australian hip fracture registry and the Australian fragility fracture registry.
New Zealand have done the same then, right?
Yeah, absolutely. So we're all using exactly the same, and the same definitions, in fact, that were imported from the UK one, so that we were all, on the same page, and they'd done all their work to make sure that they fitted in with the European model. So it is a little bit Chinese whispers. We haven't done our own research to make sure the definitions all match. But for the standard ones, I know they've been copied. But I'll have a look at that OMOP standardized data model from. Yeah, I've got the website up and looking at it now.
And there's a Ugogo group who that's their interoperability solution. So the reason to mention that is that for this thing to go gangbusters, Marcus, I understand that it only takes a while, but getting anybody to do anything other than their routine clinical practice is the wicked problem, isn't it? So and hence that we need more people using it. So the second thing is, what has been the uptake of, I know it's not our preferred thing, but what has been the uptake of the New South Wales ORP tool? And so some just talking to the ACI to see what that actually looks like, because if they become the data custodians of any data being captured in that portal, then that you want that interoperability between their data set and direct data download into this registry.
Yeah, that's a good point, Chris.
Sorry, Kitten, can I just ask
Yeah.
for clarification? So with the data pool, you mean you mean the e-health identification, the case identification or case finding tool? Yeah.
So there are sites that are actually using that.
Yeah, I know. Westmead does, and I think Bankstown, could that be?
Okay.
And some others. It's quite
Japan.
interesting, actually. I talked to Chris Needs. Unfortunately, Chris has left. He was here before. But Chris yesterday actually said that tool was made available by eHealth free of cost to all sites, and very few sites picked it up, including RPA. And now
Can I interrupt you?
So now it actually costs money. If you want to have that tool, you have to pay.
So no approach was made to Southeast Sydney that was free. Okay, otherwise we would take anything that's free. What is usually offered is, yes, the tool is free, but the install, you have to find the resources internally, and then you just get in an ICT queue. So there'd be no change from about 200,000 in terms of the management costs of installing that in any operating system in any site. Okay, so eHealth is if that's the language that was coming from anybody associated with eHealth, then I can assure you that's not actually the reality. So, but whatever has happened, and wherever that happens, the low-hanging fruit is to get that interoperability between this registry and a data set that's already being acquired with in the ACR, which is where I think you will find that the data custodian is going to be the ACR, right? And then this really goes gangbusters if you can put a distributed data network over the top of all of it, and it will. And the reason that this is familiar is we've done this for ADNET. This is our proposal for dementia, and whether it's dementia, whether it's fracture, as mental block. Jackie Centre will attest. It's the interoperability between fracture registries and dementia registries that's really going to scale up the secondary use of data, which is where the unlocking the data asset really resides. And so this goes gangbusters if your spreadsheet actually just gets embedded in the EMR, right? Gets coded so that it's a worksheet in the EMR, and you get direct data download into your data registry. Then it becomes routine practice when you're in the EMR, rather than bringing up an alternative site or working with your patients in a different registry because they've had a fragility fracture, and then turning around and in an osteoporosis, is osteoporosis clinic or in a menopause clinic, thinking, oh, now I'll think about your bones, and that's managed separately. So that's like working across two systems, and that's where you're going to lose your clinician at the coalface, and it can be circumvented by getting your spreadsheet, your worksheet, because this is the information you want to capture. There needs to be some degree of plasticity around that spreadsheet, because it was pretty quick, but for instance, I didn't see romosozumab as a treatment option. Is it on your thing? Anyway, things will change.
Yeah.
Therapies that currently don't exist or didn't exist when you're putting your spreadsheet together now exist and you're not capturing it. So you need that. All I can be sure of is that the environment is going to change, and you need to be elastic and plastic to those changes. But otherwise, fantastic, congratulations, and yeah, we should.
All right, thank you very much. Appreciate those comments. That's some interesting stuff. We've already, at the moment, we have API access to the registry, so that we do have interoperability as part of the Australian standard for all registries going forward. Interoperability was built in, and so having that API allows us to do that sort of stuff. The technology is there, whether there's the will and the willingness and the permissions. Unsure. That's.
Can I just confirm you've got API access into the hip fracture registry at NERA with Jackie Close? Is that correct?
Yes.
Lovely, excellent.
So we are currently pulling data from RedCap, which is what WA use to capture all of their data, and at the flick of a button, all of that data is transferred directly into the hip fracture registry, and it generates a report to tell you what it did and how it did it. But yes, so we have API connections into hip fracture and fragility fracture. All right. Are there any other questions? No, all quiet on the Western Front. Fabulous. Curtin, have you got anything more to add?
Yeah, I think maybe anyone want to have a chat to me, easiest way to contact me is going to be email, and happy to go through any issues or questions you'd like.
Fabulous. If you are interested in getting involved, please drop us a line. Marcus, anything from you?
No, that was very good, and I hope people are coming on board. Okay, thank you.
Fabulous. And we've got all your emails, so what we'll do is I'll just put together a quick email to say thanks for joining us, and a link to this if you want to come back and have another look and watch it again. That's it for us. Enjoy the rest of your evening.
Thank you. Bye-bye. Bye.